I'm glad you prepared me for that. I always start talking and then that pops up like in the middle. Well, hello, everyone. I am Amanda Newhouse. I'm clinical social work faculty at WVU Medicine. And today I'm going to be talking about parent-child attachment. So let me share my slides. Maybe. There we go. Can everyone see this? Perfect. Okay. So whenever, for those of you who have heard my talks on attachment, I use this. This is my favorite definition of attachment, and I use it every time. It is a deep and endearing emotional bond that connects one person to another across time and space. And so I love that definition of attachment. And attachment is so very important. And when we think about attachment, it is grounded in theory. And so you saw that little quote is by Mary Ainsworth and John Bowlby, who both pioneered attachment work. But the attachment theory really states that those first relationships in an infant's life really establishes their relationships throughout their lives. And so just that trusting relationship that somebody's going to meet their need and be there for them consistently really impacts relationships throughout their life. And Bowlby actually talks about how important that consistency is in the first 6 months for the rest of their attachments throughout their lives. And so we know that that attachment within that first 6 months in actually that first 3 years of a child's life is significant. But just like that statement at the beginning says, it's over time and space. So even throughout their lives, how important attachment is. And it develops different types of attachment. And everyone, I mean, secure attachment does matter, but everyone's like, well, if they have an anxious attachment, it's bad. It's not necessarily bad. It's just different, right? It impacts their relationships and lives differently. And not that you can't build a secure attachment, but it just becomes a little more difficult over time and space if you don't. Those early interactions are just so significant. So thinking about attachment from the very beginning, prenatal attachment, a pregnant person attachment starts when a pregnant person really accepts that they're pregnant, right? And so that happens typically around the second trimester, sometimes in the first trimester. But a lot of the times there's a lot of reorganization that goes along in the first trimester. But by the second trimester, you know, the baby starts to move, the pregnant person feels that movement. A lot of those outward emotions then turn inward. And so they really start to build that just natural connection, right? Their rates and rhythms increase with one another. They learn their sleeping patterns, eating patterns, movement patterns. So that attachment really starts to build. And that's a really positive thing, because the more that a pregnant person can attach prenatally, the better postnatal development occurs. And so a lot of the research really supports that it's linked to positive postnatal development. And then pregnant people who are exposed to high stress levels, like toxic stress levels. So we all have stress, but toxic stress levels, like that constant fight or flight that you're in, like having to find resources or food or, you know, where they're going to live, or dealing with domestic violence, or dealing with their own mental health or substance use disorder, right? So these are all toxic stresses that can be negatively associated with symptoms of anxiety and depression postnatally. And that's not only in the caregiver, the pregnant person, but also in the baby. So pre-attachment, from birth to about 2 months, that's when, you know, babies are starting to gain that safety and security from their caregivers. So, you know, caregivers are the baby's emotional regulators. And so when they're distressed, it's that soothing from being distressed. It's that response to their cry, to their communication. And this comes from routines. It comes from responding to cues. And so like diaper changing, baths, feedings, right? Just holding and comforting. And so that all starts and builds attachment from the very beginning. So just kind of meeting some of those basic needs. And then come 2 to 7 months, that's when attachment really starts to take place. Infants become a little more selective with their caregivers and show preference. And a lot of the times, you hear a lot more about moms being the preferred caregiver. Fathers sometimes get a little frustrated, or other partners that are not the primary caregivers will say, oh, I can't soothe them. They always cry. They cry when you leave. They cry when I can't feed them. And so, but that's typical. It doesn't mean they're not attaching to that individual, but they prefer that caregiver, right? They prefer something about them that they like. It could be a scent, it could be a smell, it could be how they're caretaking for them. It could be their stress levels, right? And so that's where their preference starts to begin. And you start to get a little more increased interaction, right? Some smiles, some more eye following, some movement. And so you start to get some of this. Come 9 months, they get to be super mobile. So they're really starting to just kind of wander and identify things. And you can almost see what they're looking at, or kind of anticipate what they're thinking. And so this is a nice stage for attachment. And then between 18 and 24 months, there's a clear-cut attachment, right? Like we were talking about them becoming more mobile. And that's one of the ways that you can identify attachment is then infants start to explore their environment. They don't really explore much, or sometimes they're very risk-taking when they don't have that secure attachment. Because what happens is when they start to trust their caregivers and those individuals who are taking care of them and just meeting kind of those basic needs, then they feel comfortable to trust their environment and figure these caregivers aren't going to put me in an environment that's not safe, right? And so they start to explore, they're moving around, but they check back with that secure base. So they'll check back with their caregivers, make sure they're still there. Or sometimes you'll see little ones just kind of like hold on to their parent's leg or arm while they start to venture off, or grab a toy, or take a couple minutes to warm up. And so that's that secure attachment. And now they start to have that cognitive. So this is object permanence too that starts to take place. They have that cognitive capability to understand that, okay, if mom goes to work, she's coming back, right? If dad goes into the bathroom, he's coming back sometimes. So they start to understand that there's going to be a return of that caregiver. And there's also separation anxiety that starts here, right? It kind of, it peaks there at 18 months. And so you start to get some of that separation anxiety. So there are a lot of influences on attachment, the interactions, right? So how caregivers respond to those cues, develop some of that sensitivity to what their infant's needs are, accepting, being warm and responsive. So how that interaction is occurring, and the infant's biological makeup themselves, right? So a lot of the times when we work with caregivers who have, or infants who have been exposed to any type of substance in utero, sometimes the nervous system is a little more stimulated, and so some of their temperament can be impacted by that, which influences their caregiving, right, and attachment, and sometimes their soothability. Sometimes infants are very difficult to soothe, and if you've held a crying baby for over 2 hours, you know that it's most likely that you're not going to stay calm that whole time, right? For me, it's like 25 minutes and then I'm done. So I couldn't imagine for 2 hours, but that happens sometimes. So infant's temperament needs to be taken into consideration. And stress levels, right? Support is huge in these time frames. Like I said, having somebody there to pick up when you're done and you're tapped out, and making sure that you're able to manage your own stresses and remain emotionally available. That's important. But sometimes that doesn't happen. So that's a huge influence on attachment. Cultural responses. So what is an individual's belief about child rearing and how they should raise their children and how they should respond, right? We hear some of the myths of, and I get asked this all the time, about picking babies up too much, right? You'll spoil the baby if you pick them up too much. That's a cultural perception, right? Some families strongly believe that, and you'll have parents and in-laws saying, don't pick that baby up. You're going to spoil that baby if you pick them up. And so the reality is you really should, 6 months and under, you should respond to all the baby's cues. You're never going to spoil them that early. But cultural factors come into it. So understanding an individual's cultural perception on child rearing is a huge influence on attachment, and exploring that. And childcare. So who cares for the child? How that's kind of viewed and how it's accepted within the family dynamics. I had a family, I love this family, and I respected their childcare and their cultural perception of this. But their whole cultural perception was that grandparents raised the child. And not that the parents aren't there, they're there. But they don't overstep those boundaries. They allow the grandparents to respond to the child first as their primary caregiver. And so then what happens is the child first attaches to that grandparent, and then the parents as their secondary caregivers, right? And that's okay. That's all right. There's nothing wrong with that. That doesn't, it influences attachment with those parents, but that's their cultural beliefs. So they're still emotionally available. And sometimes it's both. So you still have to, as a parent, really kind of explore if you have ambivalence around that. So who do babies become attached to? Mary Ainsworth, thought that babies can become attached to multiple caregivers, but there is a hierarchy in their attachment figures, which kind of goes back to that theory that they're going to have that preference, right? And so typically mothers are the primary attachment figures. And once they have that firm foundation, they kind of veer out, right, to fathers, other relatives, caregivers, and peers. And you see this with well-attached babies and children. And sometimes when there's early disruption in attachment, then you can see that they don't get along with other people, right, other relatives. They don't really trust other relatives. Peers, they become aggressive with peers and poor interactions with peers. Sometimes isolation with peers, they don't want to be around them. And sometimes that has been influenced by attachment. So we do see this a lot more. And I just want to hit that dads matter, because I know when we talk about attachment, a lot of the times moms are considered the primary caregivers, but there are many families where that is not the factor, and dads matter. Dads are huge influence on attachment and child development altogether. There's tons of research that identifies that fathers that stay involved raise children that are less aggressive and most likely to be successful in school, as well as handling stresses and frustrations well. So dads have kind of this ability to help kids regulate emotions in a more rough way. The research has shown that the rough and tumble play is really important and significant, and the tone of their voice is very important and significant. There's not been a lot of research done with same-sex relationships, but the research that's out there is that when it's a primarily female same-sex relationship, just having a strong male role model is important, because still, again, that tone and that kind of rough play is really important. So secure attachment does matter, but it doesn't mean that they're wrong if there's other types of attachment. It's important for self-reliance, persistence and task taking, right? Again, think about it in that process. If they have that secure, trusting attachment early on, that consistency, then they trust their environment. They feel more comfortable taking risks, pursuing tasks, right? A lot of the times, if that early disruption happens in the front end, then they're not feeling comfortable in these later pieces, right? And that's part of brain development as well. It's building empathy and social competence. And so these next few slides, we're going to look, and I want you guys, we'll kind of process a little bit through it. But we're going to look at a secure attachment, and we're going to look at some of these interactions, because part of attachment is, and if you think about some of the population we work with, like a lot of the times when we work with individuals who have substance use disorder, and in a later slide I talk about it, we know that we have a high percentage of women who have a substance use disorder also have complex trauma. And complex trauma is tied into emotional attunement. And so being emotionally available for their child is really important, and working on that is really important. But many of the times their trauma can kind of creep in there. And so, you know, a piece that could be healthy development can easily be derailed without some just natural support, as well as everyone's support. And we'll talk about even how providers can support them throughout this. But it's really important to promote that, because the reality is that you know, attachment occurs from those interactions, right? That serve and return between infant and a parent. And what happens is you have that match, that togetherness, mismatch, and then a repair, right? And so if you think about an infant and a parent, what would be the percentage of time in a day that they match? What do you guys think? Take some guesses. Let me see if I can pull up the chat. What would be the percentage of time that an infant and a caregiver match? So if we talk about those interactions happening where an infant kind of matches with their caregiver, then there's a mismatch, and then there's usually a repair that kind of comes in. So those are like typical interactions, right? It's that serve and return. It's a smile, get a smile back from the parent, and then kind of stop. What do you think that percentage is that they match? Anna says about 70% they match, right? Any other guesses?
I was thinking 50%.
50%, so half of the time. Okay, Robin says 50% too. Any other guesses? It's actually 60%. So Preston says 60%. It's actually 20% of the time. So babies and caregivers only match about 20% of the time. So think of that. Most of the time is repairing. And if we don't catch that, they can derail within their relationship. And I think of some of the patients I work with, and I think of how easy that could be derailed, right? Some of that shame and guilt that can creep in there, like, oh, they're not smiling back because of me, or I did this, or, you know, they're mad at me, so I'm a poor parent, right? Like some of these like intrusive thoughts that can just kind of come in and just promote that derailment that occurs when it's natural that only 20% really match of their time. And so that's really interesting. So let's look at these next slides and you can see exactly where that happens.
So babies are very forgiving. That's good.
Babies are very forgiving, right? We are the regulators. They're looking to us. Okay, so this is like a still-faced experiment. This is actually T. Barry Brazelton's still-faced experiment. So T. Barry Brazelton was a pediatrician who really works on relationships and building that early attachment, and really promotes parents having some of that anticipatory guidance of like, what is typical child development, just like we talked about that 20% being mismatched, right? And coming in beside parents and really helping support them so that they are building these healthy relationships and repairing them along the way. So this is actually a split screen. The mother is looking directly at the infant. And so you'll see the infant's responses. And so in this first one, you can see they're matching, right? They're matching. He's like, yeah, and she's smiling. They're both smiling. And then she comes in and he grabs her hair, right? And so then she's like, ouch, 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 and pulling away, right? Ow, ow, ow. Suddenly the tone has changed. The interaction has changed. That's a typical interaction for an infant. And then you see the response. Look at her face, right? It's very different. Her face is no longer smiling, and look at his face. He just paused. His hands go down. He's kind of pausing, kind of a half smile looking at her. And she's like, still like, ow. And then you see him become distressed, like, oh, oh. And so he can't take it. And for infants, this is kind of when they dysregulate, this is what they do. They'll either look away, they'll cover their eyes. I just had a parenting group. One of the little ones would get shy and she'd cover her eyes real quick, right? That's dysregulation. So he's dysregulating. He's like, whoa, like this was a mismatch. Something's going on. And here she comes in for the repair. You see her automatically like, oh, oh. And then she's still trying to come in, softly touch him. Here she's softened her face. Look at him peeking, right? So he's just like kind of peeking up, like, what's going on? Is she still mad at me? What is happening? Am I still this? And there's the repair, right? She's laughing, he's laughing, and how quick that repair can happen, right? That's a secure attachment. But think of a parent that might get mad or have intrusive thoughts or easy to anger, right? Or maybe that's a trigger. Let's think of our trauma patients who've had their hair pulled during significant attacks or abuse, right? And how triggering that can be. And that pain feeling that sets off their fight or flight. And not always do they come in for that repair. And so helping people and coming beside them and just kind of promoting some of that repair is really important. And those moments to kind of bring back together, because if not, it derails. But how fast that can happen, right? Like right within a second. And all babies go for hair, dangly things, earrings, right? Glasses. So that can happen very quickly, but it is really important. That secure attachment is really important, and that reciprocity, right? So we know that that recognition from early on, recognition of the caregivers that they're going to be taken care of, that familiarity leads to them feeling more comfortable. Being comfortable leads to them exploring their environments, and gaining pleasure and doing things and having fun. And that builds resilience, right? Their ability to come back to a situation or continue to be persistent, and then build preference in the relationships that they come across. So we know that disruption in early attachment affects regulation, and affect. It also affects their ability to be socially competent, and the rest of their relationships. It can increase aggressive behaviors, and decrease the ability to learn, right? Because that comes from their attention, their stimulation, and then that ability to kind of regulate and focus, and possibly later psychopathology. And so early disruption in attachment is huge. There is a difference between attachment and bonding. And so attachment is just that emotional connection, like we talked about earlier. Having that emotional connection that you're just connecting, right? It just happens in the moment. It happens through your thoughts. And then bonding is that intentional relationship building. And bonding can lead to attachment, right? Once you start to build that intentional piece, that becomes consistent, and then you can build on your attachment. But that's the difference between the two. And they're both very important for child development. Again, like we talked about, babies are born with all of the neuroreceptors that they'll ever need, but they need those synapses to fire and wire together. So they need that positive interaction. And so their brains are just waiting for that, right? So both physical and social emotional nourishment, they need both of those things to really build that attachment early on, and how important that is. They get that from their basic needs, from communication, relationships, and stimulation. And so that stimulation of that serve and return that we see with babies, and how very important that is. And so we see this within brain development, right? And if you look, that fight, flight, or freeze is right there at the bottom of that staircase. That staircase is your amygdala, and your amygdala is completely, first 5 years, that whole upstairs part of the brain and the amygdala is, that staircase is just completely underdeveloped. And so everything that goes to the brain is pretty much emotional. And so you have that fight, flight, or freeze response. And when that's ignited and not kind of regulated, then it's really hard for the rest of that brain to develop. And you can see that upstairs piece is so really important, right? And so it's so important for thinking and decision making and controlling their bodies and being empathetic. And so it's really underdeveloped. And that's why we're seeing a lot of kids that are social emotionally delayed right now, because that bottom part is so stimulated, and they're having a hard time building kind of the rest of it. Now we know that when we're working with mothers in recovery, that it is a little different, right? So mothers in recovery are really highly motivated. They tend to be younger, so they're less progressed in their disease. They have some support, still feeling very overwhelmed, but really hopeful for the future, and a lot of willingness. And so we do see a lot of willingness and support in mothers in recovery. And what we tend to focus on is, you know, a lot of the times when I'm working with mothers in recovery and mothers who have, you know, lost their babies initially, working towards that. And so we kind of work towards that and promote how to do that, how to build this attachment from a distance. And we'll talk a little more about some of that. So I covered this. We talked about a lot of the times women in recovery having some of that complex trauma and knowing that that's linked to emotional attunement, and teaching families to be more emotionally aware and available for their children is really important, because we're dealing with a very traumatized population a lot of the times. So how providers can help, and we want to identify what feelings we're bringing to the situation, right? What is our biases? How are we looking at it? So that we can authentically engage. When we authentically engage, we can really come beside caregivers so that in promoting them to be better caregivers, and just by providing that support sometimes, and that natural guidance can be really beneficial and go a really long way by building that trusting relationship. Positive thoughts promote positive interactions. I think this is really important. A lot of the times I use this for myself, and I use it in supervision a whole lot, is that if I have a supervisee talking poorly about a family, I stop them and have them recognize those thoughts and feelings that they may be experiencing. Because if they're talking poorly, and naturally you have like a safe space for people to talk every now and then, but if they're coming back consistently and talking poorly about a family, I really explore that with them, because if they're talking poorly about a family, the chances are they're feeling poorly about the family, and that the family is feeling that as well. And so we really want to kind of explore that and make sure that they're positively talking and looking towards a family. And actually, going back to T. Berry Brazelton has these set of parent assumptions that we go by as a foundation, which is like all parents have strengths, parents are the experts. It's natural for parents to have ambivalent feelings. So really these kind of assumptions into positively promoting a strength-based approach. Reassuring confidentiality as providers. I think this is really important. We live in a very rural area, and many of the times people are familiar with everyone around them, and they get very nervous about that. Bringing compassion and not consequences. So really trying to be compassionate. Now, there are definitely times for consequences, but I feel like sometimes we go too fast into consequences. And so really understanding compassion and where some of this could be coming from. So what we want to do is explore and build with compassion, build that mother sensitivity, right? The mother sensitivity of being aware of their child's needs and what those needs are, and responding to the cues. And sometimes it's hard when individuals have not grown up in being responded to themselves. They have a hard time identifying some of those cues. Understanding parenting behaviors. What are their beliefs? How do they parent? And what are some parenting pieces that they can do and they can participate in, and without really correcting and telling them, right? We can do that just by promoting what they're doing right, and what they can do, and what they have done, by exploring some of that internal working model. So this is another piece that we use in infant mental health, is that internal working model. And really what that is helping a parent just rebuild and reconnect, right? Building that attachment. What was it like when you first found out you were pregnant? And who did you tell? And what did you think? And so you're reflecting with them. You're reflecting with them on being emotionally available, and connecting those emotions to that child, so that they can rebuild that. Parenting from a distance. So like I was saying, parenting from a distance is huge. I work with a lot of parents on parenting from a distance. They don't have custody of their children. So ways that they can interact and parent from a distance by promoting some of that positive interaction when they do see their children. I had one that I had a patient that would travel like 3 hours to see her kids for an hour and then 3 hours back. And she would spend that time because, you know, the baby had diaper rash a couple times and she was concerned that they were using something the baby was allergic to. So she would spend that time like evaluating the baby and looking up and down for bruises and diaper rash and making sure she's getting what she needs. And so we talked about, you know, staying in the moment and how that takes away from that interaction, right? And but you can definitely understand that's a stressor. And so being able to process that and kind of parent from a distance, that kind of her feelings, underlying feelings of guilt and shame that she ended processing through, so that she could be present and emotionally available for that child. And that's really important. And I think it's really hard for some of the population that we're working with. I think it's really difficult when we have babies that are removed and placed in several homes over and over again, right? Because that kind of takes away from that early attachment, regardless of that primary caregiver was not present, right? And like, for example, I had a mom that, you know, she was in recovery, doing well, and relapsed on New Year's Eve. And so when she delivered in February, the baby was removed from her care, but she had a plan in place, right? She was going to place the baby with her aunt, and work hard. And she did work very hard. The baby was placed with her aunt. Her aunt could not soothe the baby, had a very difficult time caring for the baby. So after 3 weeks, the baby was then placed with her cousin, who had 4 other children and could not care for the baby, and then was placed in a foster care home and then placed in another foster care home. And at 6 months, the baby returned to mom. But if you think about that, that's what, 5 caregivers, right? Within the first 6 months of that baby's life. So that attachment is strained then at that point. They didn't have time to really attach to one individual. And so, you know, I think that can be really difficult. And so that can be a disruption in attachment, but there is opportunity for mending and repairing. And like I said before, you could still build a secure attachment. It's just way more difficult. But those attachments are really important for trusting relationships. And so building and that's a parallel process. So building a trusting relationship with that primary caregiver is really important, and coming alongside. And the reality is when we do that, we're really promoting that whole family system, right? So not even just that individual, we're promoting that whole family system. And so that can be really beneficial for not only one individual, but the whole system themselves. Okay, and this is, so does anybody know what hormone's lighting up here? Any wild guesses?
Oxytocin?
Yes. So it's oxytocin. This is the love hormone, right? And so this shows that interaction, right? This is a mom that's kissing her baby on the forehead, and look at the love that baby is feeling, but more, look at the love that mom is feeling, right? And so that's really reciprocated. And we know in working with the substance use disorder population that that's really necessary in recovery, is that endorphin producing ability to care for your child, right? And see how healthy they are for one another. And so promoting that relationship as much as we can, within the realms of safety, is really important. And I think you can see how important that is for mom as much as baby. So this is one of my favorite quotes that I put in. I needed someone to love me when I could not love myself. This helped me love my baby more. So this is about a mom that was in recovery and her nurse. So the nurse really came alongside mom, like beautifully came alongside mom, and was like, oh my gosh, the way that you respond to her cry is just perfect. And I love the way you held her tight. And then when you got tired, you put her in the, you know, and she was safe in her crib. And so like she didn't correct her, she just supported her, right? She just came alongside her and really supported her and made this person feel loved. And what she had told me was that she really wasn't sure what kind of mom she was going to be, but the fact that this nurse had faith in her made her feel loved so that she could love her baby more. And she said, I wanted to do better, and I wanted to do all the classes, and I wanted to do anything I could to make my baby feel loved. And so I just thought that was beautiful. And this mom and baby ended up staying together, so that was even better. But I just thought that was wonderful. So building those protective factors are really important. When we look at protective factors that build resiliency, it's those concrete resources, making sure individuals have, housing and food and parenting courses and parenting evaluations. And, this is something that I always say, like, my patients are super resilient when it comes to this, because the amount of planning and resources that they get involved with and attempt to complete and do, part of their treatment plan is usually stable housing and getting a job and attending parenting classes and doing their UDSs and attending treatment. And I think of all of the commitment they put into these things, and I think to myself, with a full-time job, if I were required to do all of that, there is no way I would be able to no way. I've thought about this over and over again all the time. Like, there's no way I could do that. So I mean, I think the amount of resiliency there is just amazing. Strengthening their support systems, because we know the more that individuals have support, the more it can reduce their stress levels, which also reduces risks of relapse, right? And so we want to strengthen those support systems to help individuals maintain their stress levels. And parenting is hard enough. And so parenting in recovery while you're trying to stabilize your own emotions and stay emotionally available for another human being is such a huge struggle. And think about having 3 of those human beings. And so again, the resiliency is just amazing. Being able to provide emotional and psychological resilience in caregivers, so promoting their own treatment and taking care of themselves and self-care. I don't think I go by one group where I'm not saying, okay, what are you doing for yourself? And where's your self-care? And so making sure that they are taking care of themselves. Parenting education, tips, courses. I do a parenting course. I have this grant that I'm doing a parenting course that starts this Friday, and I met a new mom from down south, and she's like involved in so many parenting pieces. And I was like, why do you want to take I was like, I'm really excited for you, but why do you want to take this parenting group? And she's like, I just want everything possible that could help me. And like, she told me things she wants help with, and I told her how that it would help her and what it could help her with. But just that retainment, and we know that in learning, repetition is really helpful for retention and retaining that information. So it's beneficial, but I thought that was just amazing too. And understanding a child's social, emotional, and cognitive capacities. We go to the pediatricians and they tell us like where they should be growth wise and how many words they should be saying, but we don't always know like if they should be playing with their friends and if the tantrums should be occurring and how long tantrums should occur. And so we don't always know that. So I think providing parents sometimes with that education is really important. And understanding their development and their relationships. So those developmental frameworks and those relational frameworks are really important to explore. It helps reduce some of that anxiety. I had a mom one time, I went to visit her in the hospital, and I tell this story all the time because I just like the visual and hearing her take a deep breath was just huge. But she was like, I walked in and her mother-in-law was in there with her, which is always so fun, right? And her mother-in-law is telling her how to care for the baby, and she should be changing the baby. And so her mother-in-law went out for a cigarette, and she said to me, she's like, I don't think I know the baby's cries. And I said, what do you mean? And she goes, my mother-in-law knows every time when she's crying that she's hungry or that she needs a diaper change. And I said, well, your mother-in-law raised 5 kids. So she's pretty well aware of like what could be going on and exploring that. This is your first child. And really, you don't distinguish between cries until about 6 weeks. And she was like, oh, like she just immediately relaxed. And it's just that developmental framework, right? Just knowing when that should happen and she's not off track, right? It's just really important in what stress relieving that was for her. And so I think that's really important too, is just to provide some of that education. Building resiliency really helps in the long run. We know that it helps with developmental tasks and moving forward and really promoting just healthy relationships all the way along the way. And so if we start from the beginning, it's super helpful because it's easier to build strong, it's easier to build strong children than to repair broken men. And that's so true, right? All right. Any questions? All right, well, thank you all for having me. I will let Laura do her case presentation.
Thanks, Amanda. We appreciate it.
Thanks, Amanda. I have lots of questions in my case presentation, so we'll get to them there. So I'm going to should I share my screen, Jay?
Sure, go ahead.
People can see this. So this is, whoops, that's not the right thing. I'll make this bigger. Can people see this?
Yeah, looks good.
So this is kind of a typical client, but based loosely on someone that Anna and I have worked with, and I don't think Amanda's worked with this person, but but this is a common thing that we see. So an individual was referred to us for treatment for opioid use disorder during pregnancy. And this individual came in, she was able to abstain from opioids throughout her pregnancy, but she struggled with methamphetamine use throughout her pregnancy. As a result, the
Hey,
baby
Laura.
was removed.
Laura,
yeah.
I don't mean, can you try to make it a little bit bigger? We got a comment.
Bigger.
Yeah.
Okay. So as a result, the baby was removed from her custody at the hospital. And placed in kinship foster care with her mother. And then she went directly to residential treatment and then has remained in outpatient treatment since then. So it's been about 8 months. So in terms of what phase the client is in, so the child is in kinship foster care and the mother has visitation. There were no visits in the first 3 months. And so this is where some of my first questions for Amanda come in. The patient was told this was due to a computer system change. I think it was in the fall, and there was a big change with CPS and the computer system or the database system, and they were not able to schedule visits for those first 3 months, but even though the mom was testing negative, which was super frustrating. Now the baby is 8 months old, and despite the mother not having any positive screens, all of her screens have been negative. She still only has 4 hours of supervised visits a week. So my first question, Amanda, is really like how, if there's been separation from parents for those first 3 months and the child is in foster care or kinship care, how does the mom like really work on that attachment bond with the now like 8-month-old child?
Sorry, I couldn't find my unmute. No, I think that's a really good question. And I think a lot of the times when I talk about that prenatal attachment piece, that's really significant because those rates and rhythms that occur create this natural kind of flow that babies become attached to as well. And so sometimes like adopted families don't understand sometimes that they're like, I've had that baby since they came out of their mother. Like literally I was there and present, right? I don't understand why we're having some of these complications. Well, it's because there was still distress there, right? There's still distress because they're memorizing. And not only that, they memorize, they start to identify 2 voices outside of their mothers. So 3 voices together within the 3rd trimester. And so when it's different voices, different rates and rhythms, different flows, it's a loss, right? It's a loss. It's their world. They don't understand and they don't really feel safe and secure. So it almost puts them back in their development. So like you're talking about, there's distress already there and then placed with a foster care. So now they're starting to identify these caregivers. And really what they need to do, the parents, when they're placed in these like supervised visits, the 4 hours, is really just focus on the interactions between the 2. And like I've talked about that match, mismatch, and repair. somebody that could be there to just kind of promote that, right? Like if the baby gets distressed, say, oh, they're looking for you, or, they're enjoying being in your arms, just a little uncomfortable, right? Like just kind of delivering observations, right? I mean, I'm sure that gets annoying to parents, but if they had somebody that could support them off and on a little bit, it could be beneficial. But parents could also just have that serve and return, right? And depending on their developmental stage. So at 8 months, really, like, they could be playing peekaboo, they could be cooing at them. So really some of those basic pieces of just being there, responding to them and taking care of them, and just returning whatever verbalizations they have, like, also kind of, like narrating where they're looking and what they're pointing at and what they're doing, and just constantly talking to them so that they recognize their voices and their stares, allowing them to stare, right? Some people, I had one mom that would get super uncomfortable with their infant staring at them all the time. She's like, all she does is stare. And I said, she's memorizing you, right? She's memorizing your face. She's recognizing you. You have 2 hours of time with her. Let her stare, and stare back at her, right? And she was super uncomfortable with that. But we worked on it. We stared at each other in session. That's what we did so that she would become more comfortable, because it was more awkward for her to stare at me than her baby. So that's what we did. But those little pieces are so important.
Yeah, actually, kind of based on what you just said, I have a question for the CPS folks that are here. I know that one of the required things that this individual is doing, and most individuals are required to do when children are removed, is parenting, different versions of parenting. Do you guys know if part of that parenting curriculum is learning about the developmental stages, like at 8 months, this is what your baby's trying to do, or at 3 months, this is what your baby's trying to do? Do you guys know if that's in that content? I guess I'm looking maybe for Cassie or Cheyenne.
So in a previous job, I taught that content, and there's some, but there could definitely be more talking about what babies do at different months. But it is touched on somewhat in the curriculum.
Okay, that's super helpful. Thank you. Yeah, because that both knowledge, and then Amanda was talking about reassurance. They kind of need both, but sometimes people just need the knowledge of like what they should be doing. So ideally, that will be some of what they're learning in the parenting piece that will be really applicable to their visits.
Yeah, we've talked about, so I actually do a training for Brazelton touch points, and it talks about anticipatory guidance. And the anticipatory guidance is just understanding what developmental milestone is coming next, so they know how to interact. And I think that would be super beneficial for this population.
And then the other piece of this case is, she recently had a psychological assessment. So this is one of the challenges and barriers. Recently had a psychological assessment that was done by an outside provider that was court ordered. And according to the evaluator, it was recommended that this patient come off buprenorphine. The evaluator did not consult with her medication, with her providers at her MOUD setting. And that's not the recommendation of her providers. And we were never consulted with. So what does the court or CPS do with that information when it's not consistent with what other treatment providers are recommending? So again, I'm looking for anyone affiliated with CPS to help us with this.
Don't be shy. You can unmute and discuss, or put it in the chat if you can't unmute.
So in my experience in previous job settings, it would kind of vary based on the MDT and the weight that the MDT puts on the evaluation versus the weight that the MDT puts on any communication that they've had with the provider. And that would be taken into consideration. Probably too, what the client's attorney, how skillful they are and how knowledgeable they are, would probably also play a role.
Okay, thank you, Deborah. That's actually really helpful because it reminds us how important it is to be talking to them and letting them know, I know that this is the recommendation from this individual, this is our recommendation, and providing kind of advocacy and letters on behalf of the client with our recommendations too. Thank you. I think that's an excellent point. I always get frustrated. I mean, I'm happy to have differences of opinion, but when there's no consultation between the systems involved, it can really put the patient in a bind, not knowing what to do. And they're like, I'll do anything to get my baby back, but it may actually run against medical advice for them, but they just want to adhere to whatever's being recommended. So those were kind of my thoughts on that presentation, and specifically around, you know, the mom has expressed to me, Amanda, that she's like, she lost those first 3 months. She gets really sad that she lost those first 3 months of bonding, and I'm never going to get those back. And then she gets into anger and resentment about and directs it at CPS. It's like, hang on, you know, whoa. Being angry and resentful is not going to help you bond with your child. And how can we work through that so that you can focus on developing that bond now, even though at 8 months, it's going to be different than it would have been at 2 months.
Absolutely. And I think you're doing an amazing job, Lauren. I think that I really wish there was a way that we could be incorporating the two, because what you're doing is perfect. You're doing a reflective practice that you're reflecting on their own emotions and what's going on with them so they can stay emotionally available for this child, right? And so you're working to help them kind of get through that. And that's so important, because how many of our patients don't have that and really get derailed by that and then lose that attachment altogether. And so I think it's so significant, and it's so significant. Like, if you think about child-based foster care, like that's what focusing on what the child needs. That's what the child needs. The child needs that attachment to their parent and their caregiver. And you know, there's a lot of different places across the country that are doing this foster care, kinship care thing, where the foster placements and the kinship cares, while they go through those periods, like you're talking about this parent who couldn't see her child for 8 months, right? Like the first 3 months. And then, so for that time period, these foster care providers and the kinship care providers are writing this parent letters like it would be from the child. So today I learned how to suck on the nipple for this long period of time, right? Like, so just doing these things that help really create this emotional bond for the parent, not necessarily the child, but the child's kind of getting some of that caretaking. So they're getting some of that attachment. Then when the parent child comes together, they overcome some of those barriers a little bit quicker. And so, I mean, that's a huge piece too. And I just feel like some of this is just like low hanging fruit that if we organized it a little bit better, we could probably hit some of that.
Yeah. Absolutely. Any other thoughts or questions for anyone or Amanda?
All right, well, if there aren't any other questions, we'll adjourn this session. We'll meet again July 19th. So be on
I
the
did want to
lookout.
say one thing, Jay.
Yep. Sure.
So if people consult the schedule on July 19th, we're going to have Danielle Tacker talk about urine drug screens and drug screening in general. And we have made the decision to open this up to some abuse and neglect attorneys who also are interested in this information. And I met with them earlier next week. So that will be a little bit of an expanded audience, because I think it's great. She is an expert. She's sort of the toxicology expert at WVU Medicine. And I look forward to learning a bunch of stuff from her as well. And I know this has created a lot of confusion for both attorneys as well as Child Protective Services workers about how to interpret drug screen results. So I hope to see everyone there.
All right. Thanks, everybody.
Thank you.